In this episode, I am the interviewee by Kristen Hovet, host of the Other Autism podcast. We continue the conversation in the second half of this interview. We talk about the connections between neurodivergence, fibromyalgia, and chronic pain syndromes. I shed light on how conditions like autism and ADHD intersect with chronic health conditions and why early diagnosis and comprehensive care are essential. We share some stories and highlight the challenges neurodivergent individuals face in the medical system, emphasizing the need for compassionate, evidence-based approach to pain management. Kristen and I also tackle common misconceptions surrounding conditions like fibromyalgia, chronic fatigue syndrome, and autism, advocating for a shift towards greater empathy and validation in healthcare. Whether you're a medical professional, someone living with chronic pain, or simply curious about the link between neurodivergence and health, this episode and others offer invaluable insights and practical advice. Tune in for this important conversation on improving care for neurodivergent individuals, one story at a time. I was talking to a medical student about a month ago. I was just asking, you're doing some rotations. Have you starting to get an idea what you want to be when you grow up, right? There's a lot of types of doctors you can be. And she looked extremely healthy. Of course, like most invisible people, they look extremely healthy. And then she said, I've been having these health issues. I'm a doctor, and we learn a lot just by staring at somebody. Like, are you about to need to be intubated because you're respiratory severe distress? Or you have severe pneumonia? Do you look like you got some cancer and you lost 50 pounds and you look terrible? But she looked really healthy. And she said, I got this chronic health issue that nobody can help me with, and I've been dealing with that. And I'm like, what is it? So I got EDS and chronic fatigue syndrome. And I'm like, I specialize in that. She's what? Yeah, I actually have this podcast. I wrote a book and I talk about that, and just did an episode this summer on EDS and talk about POTS in August and Fun Nations experts. And then we started talking like we're doing. And she said, I would love to have you speak at our medical school. And she felt so validated because she knows how doctors often talk about this. So talking about stomach issues, I was seeing a baby of one of my partner's patients, infant. In the problem list, it had something that said intestinal dyskinesis or some newer name that I hadn't heard of. And it was maybe in a 5-month, 6-month-old was having some issues. What do we know about autism and overlapping syndromes of stomach issues? And I said, that's interesting. I'm just curious, can you tell me more? Because the child was just in for a cold, check for an ear infection, and mom was a doctor. And I said, that's really interesting. What kind of doctor are you? She said, I'm an anesthesiologist. And I said, I'm just curious. I've worked with a lot of people with these chronic pain syndromes and GI issues. And sometimes things run in the family like IBS and anxiety and other things. She's, yeah, that's me. I had anxiety in college and in med school. And I said, that's really interesting. We learn a lot of these stomach issues are overlapping with autism. And she's, yeah, I'm pretty sure I'm autistic. And then I thought, as you learn about this as a difference, and sometimes that difference can cause deep distress, and to say simply a difference and your child can't speak, obviously there's all these different spectrums, but wow, she picked a good job. Being an anesthesiologist, you don't have to do tons of eye contact. You're very meticulous. You do things in order and you line things up, and all of that is good. But recognizing that, and what if already at 6 months, mom's aware of her diagnosis, but at 6 months of age that her infant has this, it keys us to think about some of these issues. And then mom is understanding her issues, which then we can give the support earlier in life so that they can be aware of these. And so we don't have to wait until you're older. But often I see these families, and that's often the diagnosis is made in one family member. And then I'm either going up the family tree or down the family tree, meaning if I'm seeing the child, then I go, hey, just like the colic, hey, which of you guys has this? And most of my patients who are getting these recognized in adulthood and they have children, they don't think it's character building to have distress and struggle like they had. They would love to have their child get the support and diagnosis and recognition that they need.
From your perspective, and we talked a little bit about this, but what are some common misconceptions about fibromyalgia and similar conditions, and how can we work to dispel them?
So I think that people think it's not real. It's all in their head. I even heard somebody say to me in the autistic world, there was a doctor who worked in the developmental world of pediatrics who had said they didn't even believe autistic style brains or autism was even a real thing. So I think that this is real. When I entered into this world of fibromyalgia with all of this information and experience and looking at research that it's been done, I made a comment in some social media, Facebook, et cetera, related type things in the fibromyalgia world. And I said, I hear stories and I feel like I'm hearing stories of somebody who's got end stage cancer, that we're doing palliative care, that we aren't really able to help and reverse and hope. Most people feel there is no hope. There is just, I got to power through, and there aren't any good evidence-based solutions for this. And we do have real evidence-based solutions, and that comes from a comprehensive approach, right? When we talk about different sensory differences, we know that autistic style brains have different readings on quantitative sensory testing, like doing heat measurements. A study about 2 years ago came out that autistic people reported pain or distress at lower temperature settings with heat probes. That's the same kind of patients with fibromyalgia. So that this is real, and then if we can offer support with good comprehensive evidence-based solutions with multifaceted approach. And it's complex, but there is real hope.
And what advice do you have for neurodivergent individuals who are struggling with chronic pain syndromes when it comes to advocating for their health needs?
I think it's learning from good, reliable resources. That's what my goal is, to put out there that people can learn more and connect. I think getting good information, trusted information, recognizing this is a comprehensive approach. I think whenever you do an intervention, for example, people might say, I tried duloxetine, it didn't work. I tried this, didn't work. But using the Fibromyalgia Impact Questionnaire revised as a tool to look at functional scores, it is a tool in research to see, did somebody actually get better? Just relying on how bad is your pain isn't always a very helpful tool. But when we look at these others, you might say, well, you had a 25% improvement. Oh, but I'm still in pain. No, we told you that this isn't going to be curing you like a urinary tract infection. The biggest question I get of listeners in my podcast is, do you know anybody like you who works in my state? And I go, I don't know anybody that works in your state, but I did interview a nurse practitioner in Virginia that'll be coming out in May, her interview. She's a nurse practitioner who has fibromyalgia and ADHD, and she's read my book, and she's also into lifestyle medicine and talking about the role of diet and exercise, hopefully more and more. And that's where I try to put the book and the podcast at a level that is intelligent, that gets the respect of people who are patients who like, hey, I don't want a 5th or 6th grade level. I want to have an intelligent 12th grade level understanding, and knowing that everybody's got different science backgrounds, and try to rephrase it so that both the patient who really wants to know and also clinicians who also want to have a good education for them, to hit both. So hopefully more and more humble doctors that recognize they may have dismissed a generation of patients. I remember that in residency, residents who graduated were ahead of me and would talk about what it was like in practice. And they said, you got the worried well. You ever heard the term worried well before? That's a term in the medical in circles about healthy people now that are just worried about their health, but they're fine. Again, it's a nice way of saying hypochondria. It's like somebody's, oh, they're always worried something's wrong with them because they feel like something's wrong with them. And we just have to give them reassurance. You're fine. You're okay. Stop worrying. Stop looking for answers. You're okay. It's just, you get the point. But when it comes to co-occurring conditions, like up to 80% of people who have chronic pain syndromes have ADHD. And the more severe your chronic pain syndrome is, the more likely you are to have ADHD. It may mean that your primary care doctor in British Columbia does not have experience diagnosing and treating ADHD. If you have that, you might have to then learn about that and then bring your history to the doctor, going back to childhood, talking about what your education was like, what your experience in school, and all of these to help this. So then you might have to seek out a doctor who does that. That might end up being a psychiatrist or a nurse practitioner who has experience because maybe your family practice doctor doesn't. So you may have to do things in piecemeal. You might have to have a doctor who understands lifestyle medicine and sleep. A lot of this ends up being connecting the dots with information and how to put that in a cohesive way, learning more what autism is. As a recent patient of mine, with her and her daughter's diagnosis, who's in high school, recognizing, holy cow, this runs on both sides of the family. And unfortunately, often that was where there was substance abuse and alcoholism and marijuana use. And a patient of mine said, oh, my dad was a pothead and abused my mom. There's a good chance your dad was neurodivergent. And that was not, and he may have learned that's, not to make excuses, but he was having some emotional dysregulation and was having a lot of anxiety and stress. And sadly, he learned that was an acceptable way to treat your mom. And it's sad, right?
I guess what I was thinking about was actually like autistic doctors and other medical professionals, like how common that is. And because I have heard from some people who were former doctors and they got out of the field because they were burning out constantly. And then they realized I'm burning out because I'm autistic. So I just wonder how common that is. And I've always loved medicine, writing, communicating, and medicine. And I feel like in another universe, I'm probably a doctor because I would have loved to have been in that world more. And I'm super lucky and grateful to be in the position I am now because I get to write about medical research and talk about it and podcast about it. But definitely I avoided medicine, like actually working with patients, because I knew that I just couldn't do it. I wouldn't be able to do it with the one-on-one interactions and all of that. Yeah, it just makes me think like, how are people supported going through medical training? And when they connect the dots, if they do, what are the supports, if any?
And I think especially when we're looking at the other autism, the people who have average to above average IQ, who mask, who can on the surface get through things. I think medicine actually, there are fields that actually attract higher percentages of people who are neurodivergent. And when you start to see and look and know what to look for, as a little aside, many of my patients will say to me or make comments, and maybe you can already sense this, is, Dr. Lenz, you ask questions that no doctor has ever asked me before. And when you look at somebody who comes in who has some hints that they may be neurodivergent, just having a chronic pain syndrome should at least make you wonder, is this patient neurodivergent in some way? Are they autistic? Do they have ADHD? Do they have both? Do you have dyslexia? All these other things. You should just ask that. But if you think about having somebody, had a patient who was a teenager, was having some clues that he may be neurodivergent and some stress related to that. Family history. It turns out mom and dad have married, divorced, married, and dad is in a subspecialty of research in the field of medicine. He loves talking about the kidneys. He loves talking to doctors who like to talk about kidneys. He likes reading articles about kidneys and writing papers on kidneys and researching kidneys. But he doesn't really express love, that his wife, the terms of endearments, that his wife just goes, I don't even know if he's capable of love. And I broached, I'm like, have you ever wondered, which often, again, getting to that misunderstanding, she probably in some senses vilified her husband for having a different way of communicating. But what if we go, oh, so just because he doesn't express it in the same way doesn't mean he doesn't care about me and love me. But you're getting a different expectation from somebody, just like if you're going to that social gathering, oh, you would show love because you would play loud family games with erratic laughing and cheering at a dining table with people you don't know well and make small talk in between playing games. You're like, since you don't do that, you must not love my family. And that's unfair, right? And I actually interviewed, do you know Dr. Mel Hauser? Have you heard of her?
I've heard that name. Yeah.
Okay. Not to quiz you, but I did an episode interviewing her, I think it was 2 years ago, and she's an autistic family practice doctor. I think she'd be great to have on the podcast because she's autistic. And she discovered when her daughter had more stereotypical symptoms of autism. And like any mom of a child who has any kind of diagnosis and struggles and distress, whether it's diabetes or asthma, you want to research it, right? You want to, especially in the modern access, you want to learn about asthma or cystic fibrosis, whatever it is. And she started researching and she's like, I got a brain like that. And she was having some burnout caring for her child who had higher support needs. And she was in a classic primary care semi-rural setting and it was causing distress. So she switched her career from being on call and sleep disruption and other factors to having a clinic called All Brains Belong in Vermont, where the staff and the clinicians are autistic or understand autistic, but a lot of the patients are autistic. So a neat example of one doctor doing that to help support people. And I think about that burnout question and I go, and we talk about it, but I wonder how many of these are people who are neurodivergent? And are we really screening for neurodivergence? As you talk and say, being autistic is just a difference. That difference can cause severe distress. And when I read the book, Is It Autism by Donna Henderson, who I interviewed in October, when I saw the stat that 2 out of 3 autistic adults have had suicidal thoughts, and 1 in 3 have had an attempt or plan, and 40% of adults who attempt suicide are autistic, I don't think most suicide helplines and crisis centers are even throwing that into the equation. And often what I hear is somebody who was told these can co-occur, like bipolar, because you did something impulsive or something. And often these aren't even in the equation to consider that. And what if we looked at it as a perspective of somebody who is autistic and went through and experienced the world differently, and how can we understand them and support them better? What are your thoughts on that?
I have a lot of thoughts on that. Yeah, that's interesting. I've also had suicidal ideation. I don't think that's a surprise at this point. But when you're reaching out for help, one of the first things you'll be told or walk through is, oh, you need to build up your social life or something, which is like the wrong direction for an autistic person, especially from a neurotypical standpoint. If you're pushing all these social events, that just leads to feeling more overwhelmed and increasing burnout. And so you could have a higher support system, like technically, and still feel worse. So I just recall that being a pressure. And then also just being told certain treatment options like CBT or things that in their normal manner doesn't actually work well for a lot of autistic people. I can see the strings. You're getting me to gaslight myself, basically. For even some CBT is helpful, but a lot of the CBT that I tried felt like I was trying to change real thoughts or real perceptions. I'm not going to sit here and lie to myself. So this isn't helpful.
I had a patient of mine just about 2 years, a year and a half ago, as I'm learning more. And I had read that CBT doesn't work in autistic people. And what's funny is I'm taking care of a patient of mine who's had some chronic anxiety. I've known he worked in a band on the outside, retrospectively masking, likes music, all of this. And he said, yeah, my therapist said, there's not much else I can do for you. And he's, yeah, it wasn't really helping. We were doing cognitive behavioral therapy. And I said, I've known you for a while, but I just was reading that CBT doesn't work well in autistic people. And I've been treating you for your ADHD. And I don't know, I'm just throwing it out there because there's a lot of stuff you can learn. I don't know if that ever came up, if you ever wondered or showed up on your social media algorithm. And he's got a smile and he said, yeah, the singer in my band, she's autistic and she's been telling me you're autistic, don't you? And so support therapy is going to be different. I got a chance to interview Megan Neff, who wrote Self-Care for Autistic People. She found out as a late diagnosed woman when her child was diagnosed with autism, she started looking at the family trees. And as she's a psychologist, okay, that's my family tree, not my husband's, and started having connections. And I recommend the book for that because exactly what you say, you need exposure therapy. You just have to get out there. And that actually can be worse, especially if it's not in the right context with the right interests in the people and the things that you're interested in. It can cause stress, or it might be tailoring that with that perspective. That's why I shared with my daughter. I'm like, look, you can really help care for autistic people. That is going to be the biggest need, to help give the right perspectives. Because again, we're talking about the same people often, whether it's fibromyalgia or anxiety because of social stress, is being validated. Like you said, I don't want to have to tell me that I shouldn't feel like my stomach curl up when somebody with strong cologne walks in. It does. And it's a reaction and I can't control it. Or you just have to just breathe deeper so you can handle the sensory overload in your in-laws' house, because you just got to relax. No, I shouldn't have to just relax. Maybe somebody should explain that Kristen loves the family, but if you want to go outside for a quiet walk in nature, she'd love to talk about stuff in that setting, right?
Definitely. And when you were talking about validation, that's exactly what I want and need. And I would love to see for everyone else in the autistic and neurodivergent communities. The other thing is I want to be validated, but not infantilized. I don't know if anyone of your patients speaks about that, because I don't feel that coming from you, but I have felt it from some people who are like, they have a certain level of education about neurodiversity. So you tell them you're autistic and they're like, oh, good for you. You've accomplished so much. And they start talking to you like you're about 5, right? So that's something I've noticed. And I don't know what needs to change to start addressing that. I don't even know how to address it in the moment, because they're being nice, but I'm like an adult.
One thing is if Elaine Aron had a sequel to her book and said, HSP really meant to be autistic people, rephrased, because that was a bestseller. And if that was mea culpa, actually, this was me just describing something that better fits the autistic diagnosis, then I think that would change the perspective. You have people like you and I understanding this, but it's not regularly understood. But I think, how do we get that out there? When you've talked about that on the podcast before, on your podcast, so much resonates with me as this is the same group of people, but we're just looking at it differently.
Yeah, for Elaine Aron, she's reached millions of people probably at this point. And you try to tell someone in that group of individuals with HSP, you're probably autistic, and they feel offended. That shows that we have a long way to go as a culture to change the understanding. It should be, if you get that diagnosis, or if someone recognizes a person as autistic, that's not saying something's wrong with you, because it's currently a bad thing still. And so like I've had conversations online with HSPs who are just like, no, I can't be autistic because, and they use those things you mentioned, like I can make eye contact, even though they're not addressing the fact that it hurts them to make that sustained eye contact. Or for me, it feels I'm going to jump out of my skin. My whole body's just buzzing to get away. I don't want to jump and run away. But they don't address those things. And so it's really hard to have a conversation with HSP. So if Elaine Aron, if you're hearing this, please, I feel like you could change so many lives by just admitting that there's this other element you're missing, and just rewrite your books a little bit, and then it will address all those issues. I don't know. It's frustrating.
Yeah, and like she said in the book, it's not autistic because. I'm like, no, that's actually, you don't know autism in a more updated understanding, because they can talk, or they have these IQs and all of this, and highly sensitive, and often that's still used. Oh, so-and-so's highly sensitive. She's like an HSP, and I'm like, yeah, actually that's in modern understanding now, we call it autism. And for when I work with patients, I think the majority who have these co-occurring things, who just feel extremely validated and helped. But I think there's some who don't like me, because I'm telling them that they don't have tissue damage, but they have this nociplastic pain. Their perception is different. And oh, by the way, you might be neurodivergent. Now, I try to do that in a delicate way. And sometimes it seems silly, because many people, and probably the majority who listen to your podcast, would be like, oh my gosh, I'd be validated. I've known that for years, but I was afraid to tell a doctor because my therapist poo-pooed it or dismissed it, or a psychiatrist didn't even understand what it was. And like, oh, you're fine. You don't have that. Why worry about that? When even though they knew something was different. But not knowing that. And so knowing how some people might react, like you may have that, they're like, I don't know. And when you have somebody who you go through this and they meet the criteria and you talk through it, and I said, so do you want this in your problem list in your chart or not? And most people are like, of course, yeah. Occasionally you have somebody says, you know what? I know what it means and you know what it means, but I don't know somebody else who's going to look at this chart that's not you or I will understand what it means. So don't put it in. And then there's occasionally somebody who says, I want to be a dual citizen or might want to Canada. My autistic patients can't become Canadian citizens because I think there's these other aspects that, again, is based on an outdated understanding. Like we don't want to have people with high support needs coming to our country, right?
You've probably heard these types of questions before, but if you could wave a magic wand and you could see like certain systemic changes or innovations in the healthcare system for these neurodivergent patients, what would that look like?
I think it would be nice to get curriculum probably in the undergrad level so that this is a standard part of psychology, intro to psychology, that this is part of that. When we have an updated understanding, this is just part of their undergraduate understanding so that we know that, right? That's just basic science, neuroscience from that standpoint. And also hopefully in the curriculum within medicine. The problem is I heard there's 12% more information that medical students have to learn now than when I was in med school in the 90s. Adding more information, but it'd be nice to have somehow to incorporate that into the curriculum and weave it in. It almost is like we have to have a specialty created that is for these chronic pain syndromes. A problem in our system, chronic pain is usually looked at in a biomedical approach. So if you go to a pain doctor, they're more likely to do a biomedical intervention. They are going to be trained to put needles in the back, do injections, and try medications, but aren't trained to be screening people for neurodivergence and then understanding what that means. So it would be great if that's part of the curriculum. It probably will take neurodivergent doctors or people who love neurodivergent people, who care for people, to have that part of the curriculum and to talk and change the language. So when you talk with a medical student who has this, is not afraid. When I care for many people in the healthcare system that are loving. I have a patient of mine who was referred by another patient of mine because they're hospice nurses. What a great place if you're autistic. People are unmasking when their loved one's dying. And you can unmask as a nurse. You don't have to pretend. And yet you can have that deep compassion come through. If you're listening to my podcast, you're going to have people living with this, sometimes patients, but mostly they're guests who are lived with some chronic pain syndrome and sharing their lived experience so that other people can hear that and they can actually talk openly about what it's like. So other humble clinicians who are open to understanding patients who are dismissed and getting support for their patients, and also have evidence-based understanding, because I can't have every doctor shadow me. I can't have every medical student shadow me, but hopefully that'll start to become normal. I do think that in Canada, and I'm sure likely in Canada and the US, once a year, it's a quality of care, we screen patients for depression. That's a good thing. We've known that for decades, that people who are depressed are less likely to take medicines, more likely to die after their heart attack, all of these kind of things, right? Less likely to control diabetes. I think that we have to get into screening mode, and we screen for things, and whether we call autism just a difference or a disorder, I like to call it distress. And it causes disruption. It can. And if we can just screen in our head that there's a different way of perceiving and communicating and interacting with the world. I'll share, if I can, a story. I had a patient in her 30s. Turned out she has ADHD and is autistic, living with her long-term boyfriend. And her mom said, you can't just text him. You have to communicate with your words. Texting doesn't count. Okay, that's mom as a non-autistic person. I take care of mom too. She's a patient of mine. They went to Europe for a mother-daughter trip. moms, let's just go ask this person over here for help. And the daughters, we can't just go up there and talk to him. And they're like, moms. And then mom realized her daughter didn't mind if she went up and talked to the stranger and her daughter would stay back. But she herself didn't want to go up there. And mom's, oh, that kind of makes sense, because I remember back in high school how she'd be shy and nervous about new social gatherings, or the team gets together for a party and going to a school dance or something. And then they had a layover in Scotland. And mom's, oh, we have an unexpected layover. Might be 12 hours. Let's go explore Scotland. And the daughter's, oh my gosh, change, stress, wasn't planned. And mom's, oh. And then they got back to the States. And dad, who loves electronics, was a handsome, stoic kind of guy in high school, football guy even. And now there's homecoming at the high school. And mom's said he didn't want to go to the homecoming dinner and didn't want to go to the football game or the gathering. But mom's now, and that's okay. And I still love my husband, and I recognize that's where that autistic gene came from, and just recognize that's okay if he doesn't want to come to a loud football game, into a social gathering and make small talk with people you don't know well. I have one fascinating study that I'd love to share, but what are your thoughts on that? This is going in another direction, but I think it's fascinating and I think it's worth saying. But what are your thoughts or response to that?
I'd love to hear that. And it sounds like with that example, just like if neurotypical parents or spouses can just change their thinking, it doesn't take much. It's just like a little bit and sustained effort to educate themselves. It can mean so much, just those little tweaks and understanding. It can change relationships for sure. But yeah, I'd love to hear the study.
Two similar studies. We now understand most people who are autistic also have ADHD, but not all. They did a study in people who had ADHD and people without ADHD, and they did a simple study. They said, put your hand in a bucket of ice water, and we have a stopwatch. Tell us when your hand starts to feel pain, and hold it in there until it's unbearable, and we're just going to measure the length of time. And what they found is people with ADHD reported pain about twice as fast as those without. And they pulled their hand out almost 3 times as fast as those without ADHD. When they asked how bad was the pain from 0 to 100 when you pulled your hand out, both groups said it was 90 out of 100. Then they gave the people with ADHD methylphenidate, or Ritalin is the other name for that. And 2 hours after they got it, they repeated the same test. And there was a 210% increase on average on how long they could keep their hand in there before they reported pain. They did the similar study in middle school, I think, age kids with and without ADHD, but they did a dolometer, which is a pain meter. You push and it gets so many units of pressure. And you said, tell us when we put in these pressure points when you report pain, okay? One of the areas, the forehead, they pushed, and it turned out people with ADHD, kids with ADHD, reported pain at about 6 units of pressure. And those without ADHD, it took 12 units of pressure on the forehead before they reported pain. They did the same thing as they did with the bucket of ice water test. And they found that when they gave them methylphenidate or Ritalin, 2 hours later, in the forehead pressure testing, their pain threshold went to 11. So treating ADHD, if you have it, which is co-occurring, can help decrease our perception of pain and that sensitivity level into a more of a normal range, and normal meaning that bell curve shifted, not to the point that you don't feel things, but the distress is more into tissue damage. Because if you hold your hand in there long enough, you could seriously injure your hand in a permanent frostbite, right? If we were stranded in, I don't know, a glacier in British Columbia in a avalanche, eventually our appendages could get seriously frostbite, and we want to get them protected.
When I was listening to you, I have heard from some people, some autistic people, I don't know if they're ADHD as well, but they talk about having higher tolerance to pain in their perception. I don't know if that's correct or if they're talking about certain types of pain.
That is historically has been said that a child might burn themselves on the stove and not know it was injured. And there may be some of that, but there was a study that looked at quantitative sensory testing with heat and showed that actually autistic people did report that I think one of the more updated understanding is because communicating is different. Because of alexithymia, they may not communicate distress in the same way. So that could be part of it. And I hear that a lot in my patients who have chronic pain. They will say, Dr. Lenz, I have a really high pain tolerance. And then as we get to share and hear the stories more and just listen, I don't jump out and say this, but as the story unfolds, I'll go, earlier you said that you had a high pain tolerance. Would it maybe be better to say that you have a higher complaint tolerance because you've learned to not complain about things because you've already gone through that over the years and your mom said that's just normal to hurt everywhere. You get pain with your periods. Suck it up, buttercup. And so it's masking in one sense. That's bravado to say, yeah, I have a high pain tolerance. And if you really knew how much I'm in pain, you can't tell because I look like I'm okay. And that's often when you're communicating with people who are not autistic in an emergency setting. It may be, I don't look like I'm in distress now, but my pain is severe. Just because I don't look like I'm in distress doesn't mean I'm not in pain because I communicate differently. And you've probably heard that. And often I'll hear that on fibromyalgia sites, most of whom do not even know that they're neurodivergent, if they are. But they will say that same thing about their interaction with the medical field. And often it's the same people, just often don't even know that it's like chronic fatigue syndrome and fibromyalgia. Now we understand they're the same thing.
I guess the other question too is your book, Conquering Your Fibromyalgia podcast and book. You said that your book didn't have information about autistic folks and ADHDers.
I had information about ADHD.
Oh, okay. ADHD, but not autistic.
And yet, when you look at this, looking back, it was there. I just didn't even know that you should consider the word autism in somebody who had average to above average IQ, who could look at and talk to you like in mask, and that there was even that, didn't even know it existed. So you can't make a diagnosis. You can't make an assessment of somebody if you don't even know that's part of the differential diagnosis. I would encourage the listeners, if you get a chance to listen to this podcast, if you get a chance to listen to my podcast, to share it with friends and family. And I think you'll enjoy a lot of this broader perspective. If you're sad that you didn't get diagnosed and helped until you were later in life, recognize Margaret Mitchell, who wrote Gone with the Wind, born in 1900, she never got any help. And when you look at people who've gone through history and the misunderstandings, there were people who were on track with things in the 1800s, but then they didn't have the support. And I love caring for people who are autistic, who have ADHD, who have chronic pain syndromes, who are struggling, because it's to offer some real hope and understanding with a real comprehensive approach. And if you are in the Wisconsin area or near Wisconsin, you can make an appointment to see me.
A huge thank you to Dr. Lenz for being my guest on the Other Autism podcast. And that's all I have for you today. Thank you so much for being here. Until next time, bye.
Thanks again for listening to this episode, and thanks to Kristen Hovet for having me on her podcast. I look forward to interviewing her later this spring and share her story and what she's been doing on her podcast to help others who are autistic. Until next week, go Team Fibro.